Hi, my name is Dr. Nikhil Nanjappa and I'm a consultant gastrointestinal and a colorectal surgeon. I spent a good part of 13 years training in the art, both in India and the UK. I've now returned to practice as a consultant in Mysuru so that I can help spread awareness about colorectal and gastrointestinal disorders and give patients the treatment that they deserve. Anal fissure is an extremely painful condition that affects patients across all age groups. Patients often have a small amount of rectal bleeding that is very painful, especially when they're trying to go to the toilet. Anal fissures can be both acute and chronic, and they're often treated differently in both these conditions. Most patients with acute anal fissure, if treated properly, will have a symptom relief within a couple of weeks and can be treated without any surgical intervention at all. As I say to most of my patients, nearly 80% of patients who walk through my door with fissure in ano receive no surgical treatment at all. And for those who do, we can offer them minimally invasive techniques such as Botox, small advancement flaps, and even conventional surgery when they really do deserve it. I often treat my patients as daycare procedures for fissure in ano, and they're often home the same day with very minimal pain. Anal cancer is something that we don't often talk about or hear about. It is a type of cancer that affects the anal mucosa and the skin around the anus. It is of two types, anal cancer of the anal canal itself and anal cancer just outside the margin of the anal canal. And they're both treated very differently. Now, this cancer can be prevented with vaccination that we have for human papillomaviruses, or can be found early by doing certain techniques such as acetowhite staining, etc. in patients who are at higher risk. Anal cancers in the majority of patients recover very well with chemo and radiotherapy, which is why an MDT approach, again, is extremely important in treating patients with anal cancers. They can have very good outcomes if they are diagnosed and treated early and appropriately, and that is what we try to do with our MDT approach to anal cancer. Anal fistula or fistula in ano is a common problem that is faced by a lot of patients. They are yet again misdiagnosed and misunderstood. Patients with fistula in ano have pus discharge from the anorectal region. It is very important that we understand what the fistula is before we offer any sort of treatment. Fistula in ano and anal abscesses are very closely related, and one might lead to the other or vice versa. Patients with fistula in ano need to be diagnosed and staged appropriately to identify the exact type of fistula before we even offer any type of treatment for them. Patients will be offered treatment based on the type of fistula in ano they have and the extent of sphincters that is involved. We can offer minimally invasive techniques of video fistula surgery, laser ablation. We can offer them open conventional fistula surgery, and in some patients who have a distinct type of fistula, a lift procedure is what I often do, produces very good results, and patients are often very happy. Appendicitis is a very common problem that can occur in patients at a very early age of potentially 2 years, going all the way up to the elderly. Again, the cause for this remains different across age groups. Patients with appendicitis present with right-sided lower abdominal pain with a fever, or can have some abnormal blood markers on blood tests as well. It is very important that we diagnose appendicitis properly and are only offering treatments for patients who actually have appendicitis proven on imaging, rather than just offering an operation to anyone with these symptoms. We've seen, especially now with COVID, that we can offer non-operative management to patients with appendicitis as well. It is important that this is discussed with the patients so that they can have the benefit of having understood what the problem is and how it can be treated in different ways. The standard operation for appendicitis remains a laparoscopic appendicectomy, in which we remove the entirety of the appendix. With the advent of robotic techniques, we are able to offer robotic surgery there as well. The patients who have their appendix removed often are home within a day or two after their operation and are relatively pain-free after. Colorectal cancers are becoming increasingly common in our country. Patients with colorectal cancers present with symptoms of abdominal pain, rectal bleeding, and these red flags are often missed because they're often just told that they've got piles. Unfortunately, patients are not screened or even investigated early in the course of the treatment, leading to much more advanced disease in our country. What we offer is that we make sure that we use the opportunity at the front door when the patient presents to us with any of these red flag symptoms to opportunistically screen them for colorectal cancers. And once we've made a diagnosis, we then have an MDT approach to treating them. Patients end up with a varying combination of either surgery upfront, radiotherapy, chemotherapy upfront based on what they need at that stage. With minimally invasive techniques at our disposal, we can offer patients very good surgical treatments with laparoscopic robotic surgery, providing better outcomes, less pain, and early recovery. This is how we've tried to help patients with colorectal cancer beat the disease. MDT approach to cancer, or what is called as a multidisciplinary team approach to cancer, is the need of the hour in treating patients with cancer in our country. MDT approach varies from the conventional treatment approaches to cancer because it brings in the perspective of various specialists that is involved in the care of a cancer patient into the picture from the very start. Unfortunately, what happens is cancer care in our country remains very fragmented and patients end up getting the treatment from a specialist that they see and not what is best for them as an individual. What we've tried to establish is that we've set up an MDT team which has organ-specific oncological surgeons who are trained in that specific organ or in that system with specialist medical oncologists and radiation oncologists who are able to offer a treatment plan upfront to the patient, arguing for or against certain options that are present so that a patient receives the best possible care for that cancer at that particular stage and they're able to have better outcomes. Type of inflammatory bowel disease that affects both the young and the old. It can affect any body part from the mouth all the way down to the anus. Patients with Crohn's disease are often young and they end up facing a lifetime of symptoms that affect their quality of life. These can be abdominal pain, intestinal obstruction, anal disease that are abscesses and fistulas, and often lead a very poor quality of life because of these symptoms. Most patients are managed by medical specialists who put them on a variety of drugs and just add years to their lives rather than give them a decent quality of life. We've now got good evidence to suggest that the presence of an IBD surgeon early in the course of the disease in these patients can improve or even cure Crohn's disease in a few patients. This is what we've tried to do at our institute, where we've set up an IBD team so that we could help people with Crohn's disease live better lives rather than just add years to their existence. Incontinence, or primarily anal incontinence as my specialty, is an often untalked about disease. Unfortunately, because it mostly affects women, there is a stigma attached to the disease and people don't often explain or have come out with their symptoms. Incontinence of the anal canal can happen due to several reasons. It primarily occurs because of the trauma that is faced by a woman at the time of labor, because of improper instrumentation. It can also happen if they've had an operation to treat their hemorrhoids, fistulas, or fissures, which haven't been done in a proper manner. Incontinence is an extremely distressing symptom because it leads to loss of quality of life. It is very important that an incontinence or a pelvic floor specialist surgeon is consulted early so that they are able to diagnose the type of incontinence and are able to explain to patients what can be achieved and what is the best possible result they can hope for. And we've got various techniques that can be used to help these patients, such as the use of simple laxatives in a different manner, use bowel physiotherapy, and often allow some treatments that are much more advanced, that uses electrotherapy and certain magnetic devices around the anal canal that can help with continence. It is important that people come out with these symptoms and are more open about it so that they can get the help that they deserve. Gut attack. Oh, what is that, you may ask? People often talk about a heart attack, but a gut attack is very rarely spoken about. Precisely how you get a heart attack where the blood supply to the heart is cut off, you could have a similar thing happen to the gut, because the blood supply to the gut comes from one or two key vessels. This can present in an acute manner where the patient can have an acute attack or what is called as an acute mesenteric ischemia, or it can happen in a long protracted manner as well. Unfortunately, we don't have the same golden window of time there is for those with heart attacks, for those with mesenteric ischemia. Patient education here is very important because in the large majority of patients who present late, there is very little a surgeon can do. But if we are able to educate people and educate the general public about the possibility of there being a gut attack, we could help spread awareness and try and help a few patients at least survive this torrid illness. Hemorrhoids, or what is often referred to as piles, is misunderstood, misdiagnosed, and mistreated. Patients with any anorectal problems are just labeled as patients with piles and are often treated by a whole variety of professionals who may not even be healthcare professionals, let alone be colorectal surgeons. Hemorrhoids need to be diagnosed first. They need to be staged properly. They need to be investigated properly before we can offer any sensible treatment for patients with piles or hemorrhoids. As colorectal surgeons, what we often do is that majority of our patients are treated without any operation at all. Some patients are treated with certain outpatient procedures, and very few patients are treated with surgical approaches that can range from laser treatments to radiofrequency ablations to banding and even staple hemorrhoidectomy in a few patients. We've got some more advanced techniques in which we treat patients with hemorrhoids, and I often discharge my patients a few hours after they've had their procedures, and most people have very minimal pain and make an excellent recovery. Hernias are defined as a protrusion of an abdominal viscus through a wall that contains it. To a layperson, it can just simply be that there's a bulge that protrudes from the abdomen that can start at the very top, going all the way down to the groin. Now, hernias present in men and women in a different manner, and patients often have symptoms of pain at the hernia site or can have complications from the hernia itself, such as irreducibility, obstruction, or even strangulation. When strangulated, a hernia can be life-threatening. Hernias are different, they are of different types, they are of different sizes, they are of different locations, and they all have to be managed in a different perspective by a trained hernia surgeon. With the advances in medical and surgical technologies that we have today, we are able to offer minimally invasive techniques such as laparoscopic surgery or even robotic surgery to help our patients with hernias lead a better life after they've had their operations. We're able to discharge our patients home after their operation within a day or two with very little pain. IBS, or irritable bowel syndrome, is something that is often thrown around as a common diagnosis. Most patients with an alleged diagnosis of IBS don't actually have a diagnosis of IBS or haven't been through the rigors of proper testing at all. IBS is a term that's often used to combine a variety of symptoms that you can't explain. Patients with IBS can either have a constipatory type of IBS or a diarrheal type of IBS, and often all have abdominal pain. These patients are often young and they have a lot of absenteeism from work, leading to loss of productive days at work as well. People find it difficult to maintain a job and maintain a family because it primarily affects the young. Diagnosis of IBS is extremely important so that we can correctly know that we are treating a patient with actual IBS or not. Cognitive behavioral therapy and counseling with a specialist IBS trained surgeon or a psychiatrist is very important. because patients here need to understand that we understand their disease and we're able to offer them some treatments. Medical treatment options have evolved significantly, and we've got some good options today to treat patients with IBS and help them lead a better life.
Hi, my name is Dr. Nikhil Nanjappa. I'm a consultant gastrointestinal and colorectal surgeon. I spent a good part of 13 years training in the art both in India and the UK.
Pancreatic cancer is yet another dreaded form of cancer in the GI-HPB tract. Patients here often present late because the symptoms are not apparent at the start, and they're often confused for more mild symptoms. Patients can have jaundice, patients can have some abdominal pain, loss of weight, and other constitutional symptoms of cancer in general. Patients with pancreatic cancer need an MDT approach to diagnosis and treatment of their disease, because there is more advances that we have in the field of pancreatic cancer today than we did a few years ago. Patients can be offered a combination of treatments such as neoadjuvant chemotherapy, and we can offer them surgical treatments that involves open surgery, laparoscopic, robotic operations as well. Some patients who are at more advanced disease may benefit from palliative treatment measures that can be surgical and can be endoscopic as well. It is very important that a diagnosis is made and the general public is aware of pancreatic cancer as a disease so that we can help catch it early. Pancreatitis, which can present in one of two ways, either acute pancreatitis or chronic pancreatitis, is a problem that is faced in the general public quite often. As GI surgeons, we see both extremes of presentation. It could be the first presentation of somebody with abdominal pain as a first instance, and somebody with chronic pancreatitis who've got macroscopic changes in their pancreas or surrounding organs. Patients need to be diagnosed early. We must understand what the risk factors are. The major two risk factors for pancreatitis of both types is gallstones and alcohol consumption. Patients need to be educated about this so that we can help prevent these complications from patients. Patients should also understand that acute pancreatitis can be a fatal condition when it is of a certain variety, and that gravity needs to be explained by good communication from specialist surgeons. Acute pancreatitis, when caused by gallstones, is an indication for patients to have their gallbladder removed laparoscopically at the first admission to prevent this from happening again.
Pilonidal sinus disease is a common problem that is usually found at the very bottom of the back. It happens because there's a tuft of hair that is present within a cyst that often can get infected, leading to discharging pus or just remain an infected abscess. Now, patients with pilonidal sinus disease can be hairy on their backs, but in my practice, I've seen patients without much hair on their back have this disease as well. While treating patients with pilonidal sinus disease, we've got to fix three issues. Move the pilonidal sinus disease off the midline, lift the nasal cleft, and also remove the disease process itself. We are able to offer minimally invasive techniques for patients with mild disease, such as pit nicking or laser ablation, and patients with more complex disease will end up requiring a flap procedure that can either be a Limburg's flap or a Karnataka's flap or even a cleft lift that can be done. Even with patients with severe pilonidal sinus disease, we are often able to discharge them within a day or two after their operation, and they're almost completely pain-free within a few days after.
Stomach cancer is one of the dreaded forms of cancers that we find in the GI tract. Unfortunately, patients with stomach cancer present late because the symptoms are often ambiguous and are often confused for simple gastric ailments. Patients are bounced around several specialists even before they're offered an endoscopy, and by the time a diagnosis is made, most patients are in advanced stages of stomach cancer, which is why it is very important that patients have an MDT approach to treat this disease, because surgical treatment is not that straightforward in these patients without the addition of other supportive treatment options. Which is why an MDT approach that we have at our institute creates that atmosphere where a specialist, an organ-specific specialist of that organ, and a medical oncologist and radiation oncologist is able to sit down, have a discussion, and make a treatment plan that is suitable for that patient. Early investigation and early diagnosis is key. Earlier the patient is treated, the better outcomes they have. Ulcerative colitis is a chronic inflammatory bowel disease that affects primarily the colon and the rectum. Patients with ulcerative colitis suffer from symptoms varying from abdominal pain, diarrhea, rectal bleeding, loss of weight. Ulcerative colitis is also a significant risk factor for colorectal cancers. Patients with IBD are young and often can be old as well. Unfortunately, in our country, what happens is patients are treated wholly on the perspective of a medical gastroenterologist when they have IBD. Unfortunately, they get one spectrum of what treatment options are available and miss out on an IBD surgeon's perspective. An IBD surgeon can help elevate symptoms and reduce the risk of cancers in these patients at a much earlier stage. What we've done at our institute is that we've set up an IBD team so that a patient is treated as a patient rather than a disease with an individual doctor's perspective. Hi, I'm Dr. Nikhil Nanjappa. I've recently returned from England after having trained there for 5 years and having served as a consultant in one of the largest teaching hospitals in Europe. I've returned back to my roots now so I can serve the people of my region, Coorg and Mysore. I now practice as a consultant at Avant BKG hospitals and hope to deliver world-class care to my people.